Thanks very much for that introduction. It's lovely to be here today, and I was asked to talk a little bit about, I suppose, the public of the pandemic to date. So I'm just going to give an overview of where we've been over the last year in terms of particularly the schools, some points about children, and then I suppose some areas of a broader level with children where we need to get to. So I suppose just to remind of the public health approach in general, we like prevention more. We're quite boring. We prefer not to have patients. And I suppose in general that means that we have a high level of importance on vaccination and a high level of importance on minding exposures to try and keep case numbers as low as possible. And that really goes for sort of all infectious diseases, but certainly applies for COVID-19. And the isolation, if you're symptomatic, and awareness of symptoms is really important, and definitely so in the context of COVID-19. You then have your next layer, which is your recommendations for sort of mitigation measures and protections, and those are your IPC measures, and we work in tandem very closely with our consultant microbiology colleagues who have significant expertise in the infection prevention control measures, and we work together to consider the best public health approach. And then obviously there's the case and outbreak management that we're heavily involved with and have those statutory responsibilities for. So in terms of the schooling, a lot was made about the public health risk assessment that we undertake. And I suppose that really just to put that in context, what we did with the schools was when we were informed, notified of a case of an infectious case of COVID-19 who was infectious within a school setting. And then what we would do was take that case, we would speak to the case, we would contact the school, and then we would go through a whole list of different things, I suppose, and determine what was necessary to do. And that might have been some recommendations in terms of sort of gaps in terms of IPC measures, but also obviously the identification of close contacts and the exclusion and testing there. So really the public health risk assessment is our way as medics of taking a history. It's a slightly different history. It encompasses the history of the community, the individual, the case, the family, etc. And we use that information to consider what the impact might be, whether that's a secondary or potentially tertiary case within a facility, for example, or whether it's a case from the community and would they have impacted within the school setting. So you need that information to be informed about what you're doing and determine your actions. So I do just want to look a little bit at some of the data for children and put the context, I suppose, for children perspective. So this is a graph that shows you on the y-axis it's the number of confirmed cases of COVID-19 and on the x-axis it's these epidemiological weeks, as Killian alluded to, the way we like to talk, and that really just the start of the graph is the start of pandemic when we got our first notified cases and right up to the current time point. And you can see just early on we had that peak with wave 1 and the schools were closed and children were sort of hidden away, and we all hid away as much as possible, and things went down to a much lower level. I've marked on here various points, or it's been marked on thanks to the HPSC who've been fantastic with a lot of this data, the time points when schools and things opened, and we can see various effects. And I suppose the first thing to note is that the green line and the dotted line at the top, the dotted line represents all the age groups, the green line represents those for adults over the age of 18. So you can see much higher level all the way throughout the pandemic. Children have been quite unrepresented proportionally in terms of the number of cases, although very harmed by a lot of the restrictions. So you can see that, you know, even as the schools reopened over the summertime, at the end of summer, that was also a time when the pubs were open and people started moving around a little bit more. So we saw a lot more cases, and if you see more cases in the community, children are part of the community, they're part of families, we see more cases therefore in children. So we saw a peak and a rise around the October time, I suppose, and that settled down then. Christmas came, and we all know what happened after Christmas and January time. It was an extraordinarily difficult time, and again children were put out of the school settings and out of society again, but for a much lower level of infection than was seen elsewhere. And then as you can see, as we move on through the year, they've been bumbling along at a very low level compared with that of the adult and the community general positivity and testing. And we can see that, you know, from the end of the term in June to the start of the term then in September, there was a significant increase starting in terms of the cases that we saw, particularly in the younger adult population, who by then were the protected as the older adults. So in terms of what did we see when we went into schools, when we were notified of an infectious case who'd been in an education setting, what did we see over the course of the year? And the first thing that we noticed really was that it was remarkably stable what we were seeing, and actually it was remarkably stable across the time point of the year. So despite all the different types of variants, despite what was going on, what we were actually seeing in the school setting in the classroom was very, very similar. So this gives you data on the close contact positivity. So it's saying, this is the index case, they were infectious in school. We've identified these people who we think might be close contacts, and we have asked them to be restricting their movements and to undergo testing. And what we saw was for about every 100 close contacts that we identified, between 2 and 3 of them tested positive for COVID-19. So that was highest in the special educational sector at 3.39% over the course of the year, but the nature of those interactions are obviously very much more different. Lowest always in the post-primary and the primary sector, somewhere in between. We certainly did see a range though. We went and saw up to 7.2% positivity, and we usually saw that in the context of very high levels of community transmission, because actually what you're doing is, if you're identifying a large number of close contacts, you're also case finding in a setting, which is quite different from your actual rationale of going in, but it's a byproduct of it. You are case finding. If you've got high numbers of cases in the community, you'll find slightly higher number of cases when you test asymptomatic people. We did, of course, see plenty of outbreaks. They were largely small in number in terms of the number of onward cases, and 50% of them over the course of the year had 2 to 4 onward cases as part of them. We saw some very much larger ones, and we often publicised those. We often went out as public health to the media to ask for support in terms of local communities, to get people tested, to mind their exposures, etc. And those larger outbreaks in schools were often connected to larger community outbreaks as well. So of course, over the course of the entire year, 44% of educational facilities required our input at some point in terms of having a risk assessment, identifying close contacts and excluding children. So that means even over the course of the very difficult year that we've had with COVID-19, more than half of schools didn't have to hear from us, which I'm sure was much appreciated their end. But it did mean that about 10% of the school population was identified over the course of that academic year, and they were put out as close contacts. They were excluded and tested. And that measures fairly favourably compared with international colleagues. And I certainly know, in the UK we were talking to colleagues, and at some points 25% of their post-primary were out as close contacts. So our very tailored approach, our ring each school, our consider each setting as a unique setting, definitely helped us keep many of our children in school. And our experiences were that many of the cases were community acquired. There were clear other sources rather than the onward spread. But as I say, those outbreaks, they did happen. We did see some onward spread, but largely they were controlled and they tended to be small in nature. If we did see spread, it was often in the context of someone who's been there symptomatic. So particularly if we knew that there was an infectious case who'd had symptoms for a few days and they were an adult, we knew that there was a good chance we were going to see onward cases. Similarly, if there was a child, slightly less, but depends on the age group and the nature of their interactions, and much less in terms of if someone was asymptomatically within the school setting whilst they were infectious. We saw much less onwards there. And that was very consistent really with international findings and lots of publications that have since been presented. So our key findings really were that symptomatic attendance was one of the key problems, and that's why we've spent a lot of effort trying to educate people, trying to make sure that people are aware of their symptoms and that they take a precautionary approach, especially with younger children. Stay at home, see what's happening, and contact your GP as appropriate. Where we did see positivity, it was often at the times where we let our guards down a little bit and the IPC measures of the classrooms were less in place. For example, the break times, the friendship groups, and the staff rooms initially were a significant issue, and we often supported schools with how better to manage that, because obviously if a lot of staff members were designated as close contacts, that was operationally very challenging for schools. And some of the bus networks and the travel systems were challenging too. So from our perspective, I suppose prevention and protection, as I said, are key. With vaccination, symptom awareness and the mitigation measures that we had requested to be in place, being implemented as best possible, it will maximally help prevent the onward spread. And that was really what we were seeing, and very early on the schools got great at implementing those measures that we asked them to. And in terms of the new variants, each time we'd come back to school, there would be another new variant that was very much in the news. And we were asked, like, you know, is the slate wiped clean? Is everything different? Do we need to do something different? And I suppose by and large, you know, the way the virus transmits is very similar. It's just better at it. So unfortunately, when we want to sort of tailor off with some of our implementation, actually we need to get better at it. There's less wiggle room with those measures, but they are still effective measures. So what about Delta? So, you know, as Cillian has already outlined in his talk, from sort of June onwards, we started to see a lot more Delta, and we had some outbreaks early on in the school year with some of the early Delta cases. So we had some experience of Delta before the schools closed up at the end of June. Also, the childcare facilities were very much open pretty much throughout the whole pandemic and have done phenomenal work in those settings. And so we had experience of managing cases and incidents all over the summer through the childcare facilities. And what we saw there was pretty much unchanged from that which we'd experienced previously. Very low levels of onward transmission. And remember, these are in settings which are even more challenging to actually implement the infection prevention control measures because of the age group you're talking about, the inability to express the symptoms, and some of the sort of difficulties with ventilation in terms of child safety, leaving doors open, etc. like that. So slightly more complicated situations for us to deal with, but we didn't see anything vastly different. So week 26 was roughly when the schools packed up at the end of June, and the primary schools closed, and the ECCE year stopped for the preschool children. And at that point, roughly 4% of the school-aged children had become infected with COVID-19, just under 4%. And that's, for that week, that was around 880 cases that came to us. And that was fairly stable. There was, you know, over the course of the year, around the sort of 600 to 1,000 plus cases was what we were dealing with the 0 to 18-year-old population. But if you fast forward to week 34, when everyone's been off and enjoying their summer holidays, and the case numbers have increased particularly for the sort of older teenage, younger adult groups, that number increased to 4,057. So the week before the schools returned, we had 4 and a bit times the number of cases in 0 to 18-year-olds. So we knew that was going to be a significant challenge, because once they returned to school, that number of cases would present having had been in school. So not necessarily anything different in the school setting, not necessarily transmitting anymore, but we've now got 4.5 times the number of cases in 0 to 18-year-olds, and therefore we're going to be substantially busier. So what we found was, with the return, there were lots more cases, mainly across the schools rather than clustered within classes. And what we were seeing in the classroom was still in line with our clinical experience of increased cases previously. But what did happen was a huge increase, obviously, in testing and ascertainment in the under-13s. So the week prior to school's return, for example, kids were only tested largely as close contacts of family members. So 10,500 swabs were undertaken and about 1,600 cases identified. Fast forward 3.5 weeks into the school, because of our approach still being exactly the same, 40,000 swabs were taken, and we found just over 2,000 cases. So for 4 times the number of swabbing in that age group, we found 539 extra cases, not due to transmission by and large, but because we're essentially case finding in that setting. But the impact of that is that well over 1,000 children per day we were putting out and excluding from society as entirely well children for nearly the 2-week mark. So public health were struggling a little bit with this in terms of conceptually that now we're a vaccinated community amongst adults, and medically vulnerable adults have the option for vaccination. The impact of those cases in terms of morbidity and mortality is very different to that which it was back in January time. We knew very well by this time that children were much less affected by the adverse sequelae from infection with COVID-19. You know, the long COVID was being very carefully monitored, but so far that was reassuring. And that if we are living with COVID, and we've never taken a zero COVID policy as a country, and I make no comment about that at all, but if we are living with COVID, then we have to think about how we normalize life for children, because exclusions are so very damaging for them. All elements of their life, really. We know that education loss has a real impact on their future life, and their future earnings. We saw nationally and internationally anxiety and mental health disorders, that they were becoming far more of a systematic problem, much more increased referrals into CAM services, increased admissions into hospitals, etc. So a real problem. We saw lots of regression of skills, and lots of people talked very passionately about that, parents and schools, in terms of the regression for young children, and particularly in the special educational needs sector. Obviously a worsening and a deepening of inequalities and inequities, which is something we can't afford to go the wrong direction of. There's a very significant loss of child protection opportunities as well. We use our schools as a real framework for picking up that, and for guidance counsellors to talk to children and to safety net a lot of those things. So significant lost opportunities there. And also just general lost confidence, and a lot of teachers would talk about this, and a lot of parents would talk about this, in that young children, particularly those gross motor skills, just not being able to play as much, not socialising with their friends, and not understanding how to engage in social interactions in the same way. So you could say, well, children are resilient, they'll catch it up, and that's probably by and large true, but for how long? How long should that apply? How long is that a reasonable thing to ask our children to pay? When before it was very obvious, as a public health professional group, we wanted to cut those chains of infection because we had an unvaccinated adult population that we needed to protect. But now there is a much better level of protection with the vaccination. We needed to consider the balance with children, the balance of benefits and the balance of harms. So from our perspective, the key things were really the best bang for your buck is no one with symptoms consistent with COVID-19 should be attending school, and they should be observed and discussed with their GP as appropriate. And we really encourage going to the GP rather than walk-in centre, because we don't want to miss other diagnoses as well. You know, that's a real risk. Children are at risk of other infectious diseases that can have more significant sequelae and consequence to them. So we wanted that very much to be the core component of focused. We still really wanted all the IPC and mitigation measures to be in place, really important, and as I say, they are, you know, we're waning in terms of our interest with that, but it's really important that we still encourage everyone to comply with those as families and as communities, and that those plus the vaccination will keep us in a strong place. So in terms of other child health services, well, there is an impact. You know, kids are supposed to have 34 contacts between antenatal exposure and second level school, and many of those contacts in the community child health service were hugely impacted. The primary visit at 72 hours went ahead, and that's when we did the neonatal screening, and so that's one reason why it was prioritised so heavily, and it was in the labs as well, and they were fantastic at doing that. But there was reduced capacity across the GP checks, there was reduced capacity for the developmental checks at the normal time points to pick up opportunities to help children earlier. There was loss of school vaccination opportunities, both because schools were closed for a good bit and because there was a loss of staff able to do it. And our efforts to address that backlog, one, to identify it because of information systems is challenging, and two, to address it is still challenging because of staffing being increased elsewhere. And we do know that parents relied far more heavily in terms of going to online resources like mychild.ie. So again, what impact does that have on children and families? And you can see just from this graph, that's what it looks like dropping off the cliff in terms of the ability to actually undertake some of those developmental checks. Going along nicely until COVID hit, all the staff redeployed elsewhere, and we went down very significantly and haven't got anywhere near back up. So in terms of the opportunities, I suppose, for children's health, well, I think, you know, we've done so much to highlight and discuss the important needs for children and their opportunities matter, that education matters, that infection prevention control really matters. Coughs and sneezes spread diseases, and maybe we went too far away from that. Safeguarding really matters, inequities matter, and actually having data to find where the problems are to address them really matters. So in terms of going forward from a public health perspective, and I hope from a college perspective, we'll all vociferously advocate for these areas going forward. We've made a lot of new friends and colleagues in terms of across the education, health and government departments, and hopefully those will provide new opportunities for collegiate working. And we desperately need a children's health data management system, there's no question. So a lot still to do, and how the rest of the year unfolds will be very interesting and something we'll have to be dynamic about. But thanks for your time and listening.